Fallot's tetralogy or tetralogy of Fallot. The congenital cyanotic heart disease, which is most common. Now let's go through it in detail. So, what are the components of Fallot's tetralogy? The component include four main features. Let's go in order. VSD. Do remember there's ventricular septal defect. There is an opening in the ventricular septum, and there will be aorta overriding ventricular septal defect. That is, aorta, which is normally placed here, will displace itself, which will override both ventricular chambers. As you can see, the aorta is overriding both ventricular chamber. So this is aorta, and it's overriding. Then we have right ventricular hypertrophy. As you can see, the thickness of right ventriculum, it has undergone hypertrophy. Then we have pulmonary stenosis, both valvular and infundibular. And as you can see, the heart, which looks roughly like a boot shaped heart. So, as I mentioned here, the heart is boot shaped, classical feature of tetralogy of Fallot, wherein we see boot shape because of the right ventricular hypertrophy. As you can see, the sole will be usually, this part will be thick of a boot, and because of right ventricle, which is thickened or hypertrophied, we get boot shaped heart. So as you can see, in mild subpulmonic stenosis, it resembles isolated ventricular septal defect. That is, the shunt will be from right to left. Left to right. The shunt will be from left to right, and this will be without cyanosis. Therefore, it is called as spring tetralogy. Then we have moderate subpulmonic stenosis, wherein the it produces increased resistance to right ventricular outflow. So this is right atrium, this is right ventricle, and right atrium, right ventricle. There is subpulmonic stenosis. So blood can't flow from right ventricle into pulmonary artery. This produces increased resistance to RV flow. The blood from RV isn't flowing because there is increased resistance to the flow. This causes right-sided pressure to get increased, which approaches left ventricular pressure, or it might even exceed left ventricular pressure. There will be right ventricular to left ventricular shunt now. Initially, it was left to right. Now it has progressed to right to left. This right to left shunt produces cyanosis, which is classical Fallot tetralogy. Then, in severe subpulmonic stenosis, that is the pulmonary artery, it will be very severe. The stenosis area will be very small. Aorta increases in diameter. Pulmonary artery hypoplastic with thin wall. As you can see, the wall of pulmonary artery is very thin. Majority of infant with tetralogy of Fallot have cyanosis from birth. So this is subpulmonic stenosis, which will be very severe. Then we have a complication of tetralogy of Fallot. There will be intravascular thrombosis, severe cerebrovascular accident, embolism, brain abscess, infective endocarditis. Next, we have signs. Cyanosis will be there along with loud ejection systolic murmur. The second heart sound, P2, becomes soft and inaudible, and S2 is equal to A2. Clubbing and systolic thrill will also be seen. Next, investigations. Under investigations, we have chest X-ray. Chest X-ray, we see small pulmonary artery, large right ventricle, boot-shaped heart, as described in a previous section. Then we have ECG, wherein we can see the features of right ventricular hypertrophy. Then finally we do echocardiography. Echocardiography shows aorta not in continuous with anterior ventricular septum. And to remember this, let's see a mnemonic. Mnemonic has drop, displaced aorta, right ventricular hypertrophy, opening in the septum, pulmonary valve stenosis. And finally, under the management of tetralogy of Fallot, if it is definitive, like we need a definitive management, Total correction by surgical means in the sense there is relief of pulmonary stenosis and closure of ventricular septal defect. We also do backlog toxic shunt. This is nothing but anastomosis between subclavian artery and pulmonary artery on the same side. Then we treat cyanotic spell. To treat cyanotic spell, we administer oxygen, kneel to chest position, which is in squatting. Uh, IV fluid, we give IV fluid to increase venous return. Morphine intravenous is given, which decreases the release of catecholamine and increases RV filling. And antibiotics is given to prevent endocarditis. Fun fact, it is pronounced as Tetralogy of Fallot. And this is the summary of Fallot's tetralogy.